everyone, I am Dr. Tushar Mehta, an orthopedic surgeon and a DAMS faculty for orthopedics. Today I would like to discuss a very important topic, not only from the academic point of view, but also a very practical topic that we orthopedic clinicians see in our OPD quite often. The topic is called as medial tibial stress syndrome. Not many people have actually heard of this topic in their undergraduation usually. This is also known by the name of Shin Splints. In due course of time, you will get to know how a shin, that's the anteromedial border of tibia, is going to get splintered. So, medial tibial stress syndrome, also called as Shin Splints, is a very common cause of exertional leg pain that we see in an athlete. This athlete can be a professional athlete as well as somebody who is excessively running a lot in his day-to-day life. What is this topic all about? It's an overuse. It's a repetitive stress injury of the shin. What is that particular population which is affected? I've already spoken to you about this. Athletes, marathon runners who are into professional running or maybe into recreational running, they are commonly affected. What this condition is all about, how does it start, and what is the basic pathophysiology? The key word that I want all of you to remember here is a very important thing, that it starts with periostitis of tibia due to a lot of tibial strain under a particular load. So you are into professional athletics, you run a lot. What happens because of the constant loading of the tibia, it leads to the inflammation of the outer jacket of the bone, that is periosteum. That is what is known in our language is called as periostitis. In fact, I would like you to have a complete picture that it starts with the inflammation of the tendon, tendinitis, progressing towards periostitis, progressing towards the remodeling of the periosteum to correct itself, and that leads to a stress reaction of the tibia again. Not only this, there are associated muscular imbalances as well, in which you can have a dysfunction of the three important tendons, tibialis, posterior, anterior, and even soleus. What is this shin splint basically all about? I hope all of you remember this, that I've spoken about it, that it is primarily a periostitis of tibia. You can very clearly see here that this is that part which is having inflammation. The outer jacket of the bone, that is periosteum, is inflamed, and that is what we call as the anteromedial border of the leg. The shin has got splintered. That's why we call it shin splints. In this topic, what does an orthopedic surgeon need to look at? The biochemical abnormalities. The biomechanical abnormalities, they are very important for all of us to see. We start right from tibia. Along with tibia, we look at the knee. We try to find out that, okay, do we have any pathology inside the knee, maybe a genovarum or a valgum? Do we have any torsion of the tibia? Do we have an excess femoral anteversion? Or is there a limb length discrepancy? Or is there a foot abnormality? And what is the status of the ankle or the subtalar joint? See, this is how the actual workup of this topic starts the moment we start looking at a patient who has come to us with clinical complaints of shin splints. We start the examination right from the knee to see if there is varum or valgum. Then we come down to tibia to see any torsion is there. We get an X-ray to see any excess anteversion is there. We calculate the limb length to find any discrepancy is there, any abnormality of the foot is there. But the most important thing, as I've already mentioned, is that we try to look at the movements of the ankle and the subtalar joint, in which I have deliberately highlighted this point since it is in a very important, I would say, an MCQ as well for PG aspirants, that hyperpronation of the subtalar joint is considered to be the most important risk factor for MTSS, that is medial tibial stress syndrome. Some of you might be getting confused. What does this hyperpronation look like? This is what is a hyperpronated foot. This is an excessively hyperpronated foot. Do you see that? This is an excessively hyperpronated foot. Do you see that? So this is a classical hyperpronated foot along with a hallux valgus as such, which you can appreciate here. This is the most common risk factor associated for this condition. How does this clinically present? The first thing with which every patient of Shin Splints come to us is a vague and diffuse pain. Mind you, this is not a localized pain, this is not a specific pain, this is not a pinpoint pain. It is always a vague pain, diffuse pain. That can be there along maybe the middle tibia or the distal third of tibia, but that's not important. What is important is that the pain starts with exertion. In fact, I have highlighted this point again because it is very important in the clinical history of the patient that pain is worse at the beginning of the exercise. The moment, this is a typical complaint that we see in our day-to-day OPD, people coming to us and telling us that, doctor, I've joined the gym day before yesterday, I paid for the entire annual membership, I thought that I'll try to utilize it as best as possible. Day 2 I was doing a treadmill, it was 8.5, 9.5. The moment I stepped onto it, I rapidly escalated the speed, and the moment I started doing it, within the next 45 seconds I started having pain. So pain is worse at the beginning of the exercise, but you know what, the moment you will stop the exercise, this pain will gradually subside as well. It's not a constant pain that is related to activity. Very late stages of these people, they will develop a pain even in the resting phase, although that occurs rarely, and that in the advanced stages. Running surface, now something that I would like to tell you in public interest, that running surface plays a very important role. You should have a yielding surface. When I say a yielding surface, that is more of a grass rather than a turf. So a yielding surface like a grass surface is always better for it rather than a proper turf, because these problems occur particularly when you run on a turf, that is what we call as a thick concrete also. Now, there is something that I would like to mention here, that this pain which I told you that occurs usually during the beginning of the exercise, this pain has a discrete property that it classically occurs at the medial ridge of tibia. And even during the clinical examination, the moment you will press the medial ridge of tibia, which is quite prominent because it is more or less subcutaneous as there are no muscle tissues around, that will usually be tender at the time of presentation. The moment you will press it, the patient will wince. And you will observe that it is tender close to the origin of tibialis posterior and soleus bursae. I've gone through extensive literature of this topic, not only for teaching PG aspirants, but also have to deal with certain patients, and I have extensively gone through this, and somewhere down the line I have concluded after reading so many articles that females are having a slight more predominant involvement in this condition. X-rays, to be very honest, they are initially going to be negative, always negative. I get to experience this with my patients also. Doctor, should we get an X-ray? I tell them no, there is no need for it, because initially anything is going to be negative. There won't be anything on that X-ray. But yes, later on, if you will see a periostitis, with which I hope you remember the hallmark word with which I initiated the topic, periostitis, periosteal exhaustosis, and even one day that might land up into a stress fracture, but this is something that you see quite later. So what should we do? We should straight away go for the investigation of choice, and that is MRI. Guys, here I would like to emphasize on one more point, that initially definitely it was bone scan, but not now. It is MRI. You will find a lot of old school literature or people who are practicing according to the old school principles, even now they are advocating a triple phase bone scan. But you know what? In every text, they have clearly mentioned that MRI has replaced bone scan as the investigation of choice. There is something called as Fredrickson classification system for MTSs on MRI. I would like to conclude this classification in a way that you have grade 1, you have grade 2, 3, you have grade 4. When I say grade 1, it is very, very simple that it is a clear-cut periosteal edema. So initially on an MRI, you will just see edema, nothing else. I hope you understand this grade 1 periosteal edema. I hope you see this periosteal edema on this area. Then you have grade 2 and grade 3, which is progressive periosteal, and not only periosteal, but you do present with a bone marrow edema. So this is grade 2 and grade 3, where there is a progressive periosteal, and not only periosteal, you have a bone marrow edema as well. You can see a bone marrow edema along with a periosteal edema. And then you conclude the grade 4, which is a clear-cut stress fracture in one of the cortices. A clear-cut stress fracture in one of the cortices. You start looking at this. This is a clear-cut cortical fracture. It's a stress riser, it's a stress fracture which is initially not visible on an X-ray, and that is why you tend to go for the investigation of choice, MRI, which is called a Fredrickson grading. Now coming to the most important part, that is treatment, and as my slide is showing you that the hallmark treatment is only one, and that is rest. My only always advice to my all patients is rest is best, sir. Rest is best, madam. Along with that, if you want, you can put up ice packs, and initially ice packs are helpful because normally they present in an acute stage in which they say, doctor, now even 5 minutes of treadmill or 10 minutes of running is giving me pain. So I say, okay, fine. The first thing is to stop that eye test, to stop that inflammation. So take a rest, take some anti-inflammatory, and take ice packs. After that, I will put you up for an exercise. Since we know that hyperpronation of the subtalar joint is very important as a risk factor, so I want that people should strengthen their gastrocnemius and soleus, and I'm sure you can see with this exercise they are strengthening their plantar flexors and they are strengthening their dorsiflexors. So muscle building is a very important prerequisite to treat this condition. Soleus strengthening exercises is very, very important. Apart from that, I have a habit of prescribing some footwear modifications as well, in which I tell all my patients that please try to wear a shoe which has got a very good support. The box should be closed. The foot is not supposed to deviate. I'm sure all my students will appreciate this hyperpronation on the left only because of the weak side support. But if the side support is good, the foot will, the mechanical axis and anatomical axis will fall in one line. So footwear modification, soleus strengthening exercises, and apart from that, there are certain orthotics, there are certain insoles. You can see all are these insoles to correct the hyperpronation. So if you really wish to correct the hyperpronation, we ask an orthotist to prescribe all these insoles, and they are really helpful to correct the overpronation. Not only this, this is something that even an orthotist could do, but you know what, these days the fancy shoes, the sports shoes that are coming up, whether it's of any brand, Nike, Reebok, Adidas, they're coming with an extra shock absorption. So while running, they absorb a lot of the weight, which is giving a less of ground reaction force onto the shin, and there is less of an inflammation. My only suggestion to all my students and all my patients is, as I told you initially also, that this topic is not only for an academic purpose but for a practical purpose, like you should in public interest. Please don't mess with it. I've seen athletes ignoring it, I've seen athletes popping painkillers for it, and I've seen athletes one day landing up into complete fracture only because of this. So one should not mess with it, one should timely take care of it and get treated for it, and this is something again important. If you want me to summarize the keywords for you, of course I can. Slight female preponderance, periostitis of tibia is the classical word. X-rays are initially negative. Investigation of choice is MRI and not bone scan. In acute stages, treatment is rest along with analgesics, along with ice packs. In chronic aspect, treatment is strengthening of the muscle along with footwear modification. These are the basic things. And the most important thing, hyperpronation of the subtalar joint is the most common risk factor associated with this. Alright, with this we come towards the end of this topic. My best wishes to all of you, and I hope that next time when you see somebody coming to you and telling you that I've started doing treadmill or I've started doing running and I'm having this problem that within 5 to 10 minutes I develop this pain, you will palpate the medial ridge of tibia, and if that is tender, you will conclude that it is a medial tibial stress syndrome or Shin Splints, a very recently asked AIMS MCQ as well. Alright, thank you so much. All the best. God bless.